Protein energy wasting in CKD. When total cholesterol is less than 100 milligram per 100 ml, albumin less than 3.8 gram per 100 ml, transferrin less than 140 milligram per dl, and CRP more than 3 milligram per liter, the BMI, body mass index for height and age and sex, less than fifth centile or less than 10% of the expected change increment between the two annual measurements. So mean upper arm circumference for the age and height and gender less than fifth centile or less than 10% of the growth, failure to obtain more than 10% of the growth between the two annual measurements. And when poor growth in height and weight and gender or less than 3% or poor growth velocity less than 10%, you call it the protein energy wasting in CKD. Here you have low GFR, you have higher amount of leptin and ghrelin because they are not degraded. And apart from this, these children has uremia, anorexia, they have increased BMR, metabolic rate is higher in the CKD, and they have less protein intake. It is restricted in adult population, not in children. We do not restrict in children, and phosphate restricted diets like the milk and milk products, chocolate, and plenty of other things. So food restrictions, choice restriction is there. They have acidosis, they have anemia, they have depression, and they have infection frequently, they have oxidative stress, so leading to the growth retardation and various sorts of CV events. Events are more common when albumin is more than 38 gram and CRP more than 3 milligram per DL and lipid profile is altered. So appropriate nutrition, renal diet, more carbohydrate, the calorie target should be 120% of the DI or SDI, standard dietary intake, in the early stage of the disease. In later stage 5 and so 140% of the SDI is recommended. Iron, folic acid, multivitamins, and then your erythropoietin should be ensured. Growth hormone is needed in a good amount of time. Dialysis and transplant and adequate renal replacement therapy is the way to come out of the situation of protein energy wasting.